Yes, there are weather-related breakdowns also. In some centers, the temperature goes as high as 50 centigrade in summers, which has a problem with the cameras. Sourcing of the parts, most of the parts which we use for these slit lamps are imported and not readily available in India. In addition to this slit lamp, we now also have a iSmart system. It's our EMR, or electronic medical record system, which have been loaded on our tablets, and these tablets are now provided in each vision centers. Vision centers are managed by vision technicians. These are local people who have trained for 1 year at our main center and then put back in the community. They can do a refraction, they can see a patient on slit lamp, but they are not able to make a diagnosis. So what they do is they take a photograph and then they connect with a Skype with the secondary center doctors, and now we also have a central command center at Car Campus, Hyderabad, where this photograph is loaded and we can have access to the AMR at a computer in the main center. And like this patient had a nodular episcleritis, so we referred the patient to the nearest secondary center. This patient had a subconjunctival hemorrhage, so we just gave him some lubricating drops. The patient did not have to travel to the higher center. So this is how it functions. The doctor sitting at the command center in Hyderabad is able to talk to the patient, and he also has access to the photographs which are uploaded on the EMR center, and a teleconsult is done then and there. If there is something significant, then the patient is referred to the nearest secondary center or the tertiary center, or something as simple as a subconjunctival hemorrhage is managed then and there.
సో అందులో ఏముందంటే నార్మల్గా కంట్లో చిన్న నలక లాంటి అలా పడింది, ఏదైతే ఐరన్ పార్టికల్ అది కట్ చేశారో మీరు, అది పడింది అనమాట, నల్లగుడ్డు మీద ఉంది. సో అది తీయాల్సి ఉంటుంది. సో దానికి మీరు ఒకసారి మన దగ్గరలో ఉన్న సెకండరీ సెంటర్కి
So we keep a daily record of all the patients which are seen. We just did a rough analysis. So in 1 month, we had approximately 58% cases were of cornea, about 4% of uveitis, and about 5% were of plasty among all the teleconsults. So we are more or less, we have covered all our centers across the LVPI network. Mainly it is the iSmart tablets at the vision centers and the drone slit lamps at secondary centers. We still have to cover about 8 more centers. The next step, of course, is to integrate both the anterior and the posterior segment. And to conclude, we believe that teleophthalmology is a good tool to help us take eye care to remote rural population. We are mainly using it to screen patients for eye ailments at the vision centers, to follow up on the patients in remote locations, patients who have been operated at the secondary centers or the tertiary centers. They are followed up on the ophthalmic slit lamp, and also in difficult situations, they are used to take second opinion from the experts at the tertiary level. Thank you for your patient listening. These are our collaborators. We did get a grant from Grant Challenges for this particular project, and 5 of the 10
TP Das to the dais, the president of Vision 2020, please. Sir. Very nice presentation. I'd like to know the cost of these robotic slit lamps.
TP Das, Saraprasad Das.
So we have basically sourced the slit lamps from Appa Swami. The next generation we are making on the Zeiss. So it's the cost of the slit lamps plus the modification takes approximately.
Absolutely low.
Dr. Das? Dr. Das? We want you here. Not on the podium, on the dais. On the dais, not the podium. Dr. Mukesh, one is you said the challenge is the connectivity. I'm very sure it will be a big problem. I mean, is there any idea of calculate the cost per consultation?
The cost of consultation would be high if you keep into the, if you analyze the internet connectivity. We are spending something about 5,000 to 6,000 per month for the internet connection.
Connections, okay.
And the slit lamp per se would cost about 4 to 5 lakhs the own. So the cost would be high.
High.
There is absolutely no doubt. It's about the reachability. I do not see, I mean, the other way would be you bring the patient, you put the patient in a cab or a
Cab,
van and then
sure.
bring him. So it's
Yeah,
basically saving on the man hours, but as the numbers increases,
Yeah.
then probably
Yeah,
the
yeah,
cost would
yeah,
go down.
understand
As
that,
of
yeah,
now,
yeah.
the cost
Correct.
is high.
Yeah, okay. You want to
Just to comment on what Mukesh said was, we are using iSmart app also. So iSmart app is used being in the vision center and that drone in the secondary center. All that combined together, right now what we are doing is like the number of consultations in drone are less but more in iSmart app. So connectivity as such is being used there. So as the number of drone increases, which we predict that over a period of time it will increase as we have the posterior segment module also attached to that. So I think that will make it more cost effective. We have not done a cost effectiveness analysis.
Okay,
So right now it's not very cost effective.
okay. Thanks. Yeah. Thanks, Dr. Mukesh. I mean, now I call upon Dr. Rohit Khanna to talk about the Vision Center, a center of care in remote areas. Okay. Sorry, Rohit, just a minute. Yeah, we'll have Dr. Sandeep. We just missed him. Dr. Sandeep Bhutan from Sightsavers to talk about mechanized refraction, auto ref, photo refraction, all that modules. Yeah. Dr. Sandeep, your presentation is there or? Yeah. There, huh? Okay, we'll ask some. Can one of you, some of you check on that? Yeah. Yes, doctor.
Right. Thank you, sir. I thank the organizers and the chair for giving us an opportunity to talk about this topic as such. Being in line with the whole topic of the session around how to use technology, so I've modified the topic slightly. It's around automated screening for detection of refractive errors, and because I know other speakers are talking about adults, I'm focusing on pediatric as such. And again, just a declaration that we have no personal or organizational commercial interest in any of the devices, and all the data and the technology that has been described is from public sources. We don't have direct personal kind of usability of any of these devices. So again, these are the outline of where I'm looking at. We don't have to talk about undetected refractive error and the significance of that to this audience. We already know that's a big problem and forms a major proportion of both blindness and visual impairment, not just globally, but in India also. And some figures which everybody knows, we already have an estimate around 20-25% population requiring some sort of refractive correction. But even then, saying that refractive errors can be easily diagnosed and effectively treated with spectacles is a line that requires a lot of thinking, because even though it is theoretically quite simple, it still is the largest cause that goes around. So again, focusing on a specific group, which is pediatric or childhood refractive errors, it forms a significantly more difficult problem because of the difficulty of finding children, plus the skill and other things involved. And moreover, we also know that developmental and other aspects of the refractive errors, if not treated at this age, are much more devastating as compared to adults. So the talk is looking at how refractive errors in children are looked at. We already have these figures that a huge number of children, around 90 million, are visually impaired. And during this process, it's not about refractive errors. We're also able to look at other eye diseases like allergies, infections, which although not visually impairing, but can have other implications. So looking at that, Sightsavers, the organization that I represent, we looked at childhood eye health as one of the priority areas, looking at around the big scope of this problem, which is close to 1.2 million government schools and close to 220 million students. All of these developmental aspects where this is the most vulnerable groups. Overall health status of the child is important, not just the vision. We also know that vision is going to have a large impact on the learning. Also, it gives us an opportunity looking at the health-related behavior and the overall development of the child. And that's the reason why we looked at school health as an important area. And here is where the identification of the problem that required a technology solution comes in. The conventional approach to refractive errors is fairly simple for children. Train teachers, which is the approach that we look at, let them identify, screen the children for significant refractive errors, send in a refraction team which can do the refraction of the children who are identified or suspected, dispensing of good quality glasses, monitoring compliance to glasses, whether children are wearing it or not, and also looking at overall impact on their quality of life. Sounds fairly straightforward and should be simple. But when we actually went into implementation, from January to December, this is the data where we approached around 3,000 government schools across 6 districts in North India. Focus was on coverage and strengthening of existing systems because we wanted to be a scalable thing across all districts through the national programs. We also looked at using existing resources like teachers, ophthalmic assistants in the government sector, other NGO partners who are available, and also engaging with other educational departments like SSA and RBHK where possible. The numbers were amazing. We could screen close to 1.5 million children with the conventional approach, could refract 62,000. Prescription was around 16,000, and these numbers were looked at. But when we analyzed our data, we looked at these challenges that were there. The biggest challenge was coverage. This is a huge number of schools distributed across. Finding children out of school was a bigger problem. So getting enough coverage of this program was really difficult, even with screening almost for 15,000 teachers. Quality both at refraction level, screening level, dispensing level, it was another challenge that we were facing. Getting enough manpower to do good quality refractions at the site as well as dispensing was becoming a problem. Compliance both from screening to refractions, from refractions to children actually getting glasses, and children once they got glasses to wear them. Overall cost of the program, depending on logistics and others, was again an issue that we had to look at, and closing the loop for that matter, because it's not just limited to creating refractions, other ones. So again, as it's true to about everything, the rule of technology is everything that can be automated will be automated. And here again, we looked at what are the technology options that would be an ideal solution. And again, a spoiler alert that we couldn't find a solution as yet, but there were things that we looked at. Ease of use, it has to be usable by lower scale staff. It has to be highly accurate, reasonable accuracy. Speed of testing has to be there, operationally efficient. Durability and resilience, we saw some shows that very expensive equipment was being taken, but we need to look at durability. And of course, because if you're talking about scalability of refractive errors, it has to be low cost. It can't be massively expensive. So we looked at a couple of options, and this is where the whole concept of automated screeners or automated refractors came into play, which does take care of a portion of these problems, not all of them, but this is how we looked at them. So what is this concept of photo screeners or refractors? They have been around for a very long time. It essentially is a photographic instrument which take a photographic image of the eyes, red reflex, which is the principle of the Bruckner's test. But also there's a analysis involved which analyzes these images to look at any embryogenic factors in children. It also may detect other ocular misalignments and other sight-threatening conditions like cataracts and squints. Again, as I described, essentially it's an infrared camera which looks at the eyes and the undilated pupil, and it looks at the red reflex. It is effective in identifying anisometropias, hyperopias, but also other issues like eye misalignments, ptosis, lens opacity, others. Also, it is highly effective in younger children where we expect the refractive errors to be difficult to detect. These are few of the devices that are commercially available. It's not an exhaustive list. There may be many others which are in development. We're explaining some of them. But some of these are available commercially and have been used extensively with a lot of studies that have shown. The first of these which came up was the MTI photo screener, which is again a digital photograph. It was a manual photo-based device, but it was used extensively in a large group of people. It had very high referral rate, very good referral rates, and high screenability rates of around 96%. Because it was used in community settings, there was a high positive predictive value of around 75 to 80%, and at that moment it was looked at as a good device to be pushed. Also, subsequent devices like iScreen, which uses high digital quality photographs with a back-end analysis where the images are sent to a proprietary analytic software and it sends back the results. It does demonstrate high levels of sensitivity and specificity in a pediatric office setting, but in a community setting, we see that the sensitivity was equal or slightly lower than non-cycloplegic retinoscopies and other autorefractors. Some more devices which have come up recently, like the plus optic series of devices, which have been designed for vision screening, but have been approved by the FDA as refractors. Again, when done across pediatric facilities, not in the community, it had very high effectiveness data of sensitivity and specificity in the range of 85 to 93%, and false positive and false negative rates of 9.1 and 2.7%. Looking at some of these options, these devices could be useful for younger children. Also, again, a multitude of data has been available. The pooled figures tell us that all available technologies have their advantages and disadvantages, and most data is still available from clinical settings. We're still awaiting a lot of community-based settings, and we know that some trials are already on way. I'm aware of a couple of them by Arvind and Elbasad who are already doing some of these community-based trials, and it would be really good to get those community-based data in, and also looking at the operational efficiency, because that is another challenge that happens on these things. Some other vision screening devices which are being done at research level, like the iSpy 2020, which is automated computer software which tests the visual acuity, stereopsis, and color vision. The diopsis method, which is a VEP-based mechanism, which not only checks the vision, it also looks at optic nerve and visual cortex. The RebiScan, which is a abrometer-based device. But all of these devices are more of research tools than community application, but I kept them there just to complete. So in general, we look at all photo screeners were reasonably effective for detection of high refractive errors and non-intermittent strabismus. But generally, handheld screeners underestimated hyperopia and overestimated myopia, whereas some also overestimated astigmatism. Ambient lighting conditions, which is a problem in the community, affected most of the devices, some more to the other. And also the refraction data that was obtained from them was not regarded suitable for direct prescription. It did require either cycloplegia or in most cases, subjective acceptance. But there are other considerations which are more important from a programmatic perspective, which are on these aspects. We look at cost, as Madam also asked about. If you look at scaling up, setting up, maintaining these devices, what is the cost and how will we look at scaling up? At what level can they be deployed, looking at this consideration, at community level, at primary care or service centers? Effectiveness, we need to look at the accuracy and can it give it a large amount of coverage that can be reached to provide impact. Also looking at requirement of secondary procedures. So if a optometrist or a trained vision technician is required to do this objective, what is actually the utility going forward? And also looking at efficiency of work per unit device versus average, comprehensiveness and continuity, and of course, additional context like availability of power to recharge these devices, security of these devices, and servicing when they are taken into the field. So having said that, we definitely do not want to get in the technology trap, wherein automated systems not only amplify the efficiencies of a system, they're also likely to amplify the inefficiencies. So before we go into any such procedures, we also have to look at availability of staff to carry out subjective acceptance, linkage with good quality spectacle delivery mechanisms, ensuring high compliance rates, and monitoring value for money for these devices going in before going for scaling. Thank you.
Yeah, thanks, Dr. Sandeep. I mean, in our system, so one of the things is it's overestimation. So when you overestimate and say that you have refractive error, it's always better we screen these patients, the team which does it. In case now if you send these children to some other ophthalmologist in the local area, then we get a very negative feedback from those ophthalmologists to the children. Then you don't have anything, you have been unnecessarily referred. So that has been a big challenge. The other one is screening large number of children, because holding these devices are also very difficult. And no. Initially it's a screening. You are replacing the teacher or somebody. Yep. Next step is the examination part. Before that, some people are, somehow screening happens at 100, 200 kilometers away. Then it may be better for the local ophthalmologist to see sometimes. So the other one is the fatigue of using the thing, and third is the safety of the devices, breakage. It's also quite expensive. The cost also is a big barrier to these devices.
Sandeep, we have also used this similar thing, which I talk in my presentation anyway, and we agreed whatever you said. What we did was that after the teachers have screened, identify the children who are supposedly on their estimation not reading well the distant vision chart, use this device to screen them. But immediately do a subjective correction also. Do not prescribe a class without subjective correction. Ultimately, those who agreed to the subjective correction by the number given by the screener, only we prescribe, other one refer to the base hospital to examine them. That way, it will not as fast as you did, but then certainly safer compared to what Ravi is talking about.
Thank you. So that's exactly the point, that we are using a technology, look at a problem which was because screening such large volumes for a constant period was a difficulty. But we also have to understand that the continuity of that process, like a subjective refraction, good quality checks would also be need to put in place before we think of scaling something like this. Thank you, sir.
Thank you, Mr. Sandeep Patan. I'll call upon Dr. Rohit Khanna from LBPEI to give his talk on vision centers. How a vision center should be built up in a remote area.
Good afternoon, everybody. I'll be talking about Vision Center, a model for care in remote rural areas. This is the campus in L.V. Prasad Institute from where we come from. And this will be the outline of the talk. I will just give you an overview of what Vision Center is, what are the different components, and how are we performing in these Vision Centers, and how is Vision Center being used as a model for universal eye health coverage. What technology has the role to play, which Mukesh already has highlighted. I will just touch on it, and what impact it has created in the network. So Mukesh briefed about this eye health pyramid model, where we have center of excellence at the top and the vision guardian at the bottom. And this is the place at community level where we have the vision centers for a population of 50,000. So what we call this one secondary center for a 500,000 population, 10 vision centers again for a 500,000, one for 50,000 each, and 100 vision guardian each for 5,000, a village vision complex. So it is more like a district model in a government setting, where 500,000 to 1 million population, and where you have vision center are equivalent to, like, you have a primary health center where you have the refraction units kept, and then vision guardians are like something like community health workers or ASHA workers, what you have in the government system. So this is what we call as a village vision complex, one secondary center, 10 vision centers, and 100 vision guardians. And these are, so 10 vision centers are all, so 10 vision centers are scattered around one secondary center, and then we have vision guardians around it, and then we have different eye care projects which are revolving around the vision centers and the secondary centers. So this gives us a very comprehensive overview of what happens in a population of 500,000, which we can really show impact over a period of 5 to 10 years. Given the problem what Sandeep also pointed out, so this is what is a bilateral problem. What we found is in a population of 50,000 people, you will have at least 5,000 people who have bilateral eye problems. And if you add unilateral to it, it will be approximately another 5,000 you can add. So almost 20-25% of people in a community will have some or the other kind of eye problem. So the need is huge there. And for this, because of that concept, a population of 50,000 will have at least 20-25% with eye problem, which is approximately 10,000 people. So over a period of time, if you can take care of eye care of these people, you will be taking care of almost everybody's eye care in the population. So based on that concept, a vision center also was developed, and which covers the 50,000 population, and which was basically used to provide spectacles, refraction, and also refer cases which are having eye problem to a higher centers. Typically we don't charge here, but there are institutes who charge for the vision center, but for us vision center is absolutely free of cost. And the key HR at the vision center is a vision technician who is 1 year trained for a basic optometry course, and also hands-on training is given to them. And these are the basic functions they performed are 4 R's, which is refraction, recognition of blinding and non-blinding eye conditions, and referrals, and also they do nowadays low vision and rehabilitation also. And a typical equipment of a vision center, I won't go into details of all the equipment of a vision center, and the structure of a vision center. Typically we have an area of 500 square feet where we set up a vision center. This is the outline, and typically a vision center usually sees 300 to 450 patients per month, and dispense 90 to 120. These are average I'm talking about. Some centers may have higher based on the coverage, some centers may have lower. And the cost for us is almost 800,000 rupees. The major cost is equipment because we use a Zeiss slit lamp, but that cost can be worked around if you are using a low-end slit lamp in the vision centers. Just skip this. And there is a strict quality control monitoring at the vision centers by the clinical and the non-clinical team, which goes every month. And also one of the important success parameter of vision center is optical supply chain. So I think there is a good quality control system has to be put in place if you want to have all these systems into place, optical and clinical as well as referral and network with the community. Coming to the performance, these are the number of vision centers which have grown. So the first vision center we started in the year 91-92, which was in the city of Hyderabad, and subsequently there was a big gap of nearly 10 years, and then subsequently it leapfrogged from 2-3 vision centers in 4 to now. Right now we have 169 vision centers across the network. This is the network where we have 169 vision centers and 17 secondary centers, and by the end of this year probably we'll reach around 200 vision centers. Coming to the performance, year by year the performance is increasing, but the number of vision centers are also increasing. So last year we saw was almost 300,000 outpatients at these vision centers. And just giving an example of how this vision center was used as a universal eye coverage in one of the area where we had vision centers for almost last 10 years. So we went back and look at how much population we have covered. We can go into the details, how did we do the calculations and all. But what we found was the overall coverage was 45% of the population. So we didn't cover, still in 10 years we have not covered the entire population. And the coverage was based on need. That means people who really require eye care. Many of them were normal. So the people who really require eye care we have covered only 39%. So in 10 years we could reach only 40% of the population in the community. Still 60% are untouched in that community. We also looked at the ability of vision technicians. Can they do, apart from refraction, can they pick up other conditions? Yes, they can pick up other conditions. What we found that the glaucoma, what they picked up was almost the sensitivity was 35%. So at least of 3 glaucoma cases, they could pick up at least 1. They were missing 2 glaucomas because they were not dilating the patients. And even retinal conditions, they used to pick 1:4. So at least they were picking 1 retinal condition. So how do we make sure that we pick up the rest 3 also, and even the glaucoma remaining 2 are not missed out? So their role comes the roles of technology, which Mukesh was talking about, and we're trying to use that. And we recently found that that is not published, but what we found that with technology, the sensitivity has improved from 35% to 70% using the technology as vision center to pick up glaucoma. We have not looked at the retinal conditions right now. The cost of vision center, what we found that this was the cost effectiveness analysis done in 3 vision centers over a period of 1 year, and we found that 3 vision center combined together could save approximately $62,000, which is like 20,000 per vision center. So if you have a vision center, in 1 year you can recover the cost of entire vision center if you take all the direct and the indirect cost incurred at the vision center. This I think I will not go in details because Mukesh has already touched about iSmart apps. So these are the technologies we are using at vision centers to reduce the gap for detecting the posterior segment diseases and also management of many other conditions which Mukesh was talking about. iSmart app, which he spoke about, non-mediatic camera, tablet-based application for door-to-door screening, and drone slit lamp. This is drone what Mukesh has spoken about, and the iSmart app, which is a tablet-based application where the vision technician enters the data also. It's electronic data all now, and he can take a picture and also upload on that tab, which can be viewed at secondary center or at the command center in the base hospital. So these all things functions which have added because of iSmart app, the gap between the cities and the rural areas have reduced, and with this app with this iSmart app or technology we can do good patient care. There's a good quality control. We can sit in Hyderabad and monitor the quality of the data, what is coming in the tabs. We can also doing education of the vision center through this tab. So we always send just a minute pearl to vision center every day or a quiz kind of thing so that the vision center technicians get a stimulus to and do the quiz or take up the quiz and improve his clinical skills also. It also gives us the idea of coverage, which villages patients are coming from, and also gives the idea of how much spectacles are dispensed. So we can see everything online. So basically the idea is everything online. You sit in Hyderabad and you can monitor all these things, which you are not able to do when it was a manual system in place. So this is the initial stages when tablets were given to these vision centers and training was done. And this is the front sheet of the and this is what the tablet, they take the picture and send to the command center. So just example of 1 month we had, this was in October 2017, where we could pick up almost 2.5% of the glaucoma cases using the teleophthalmology consultation. So almost 34 glaucomas was picked up of 1362 consultation done. I'm sure there will be some missed also, but at least they were picking much more than what they were doing previously. And now this is Project Sangam, which is more like education for the vision technicians through using the tablet-based application. And this is what the impact which have created over the past 10 years. From 98 to 2014, the prevalence has gone almost 200%. It has gone down in both the areas where we had vision center for the longest duration. I'll just skip this. So this, thanks to the team of all the vision technicians, we have almost like 150, 160 working in the field. It's all because of their efforts these are happening, and I'm standing on behalf of them and speaking for their behalf. Thank you.
Very illuminating talk, Dr. Rohit Khanna. Do you check the quality of images? Does some ophthalmologist checks upon the quality of images that are taken by them?
Yeah,
Do you
because
check a certain percentage of those?
yeah, so whatever image, because a person is sitting in Hyderabad in the command center. So whenever the vision technician, he says take one more image and send it. So whenever there is a bad quality, they just tell them to take another image and send it, as long as they get a readable image.
And prescriptions are sent. Anybody else?
Thanks, Dr. Rohit. In the interest of time, we'll move on to the next presentation, which is about capacity building of grassroots eye care personnel by Dr. Monica Gandhi from Shroff Charity Eye Hospital, Delhi.
Good afternoon, and thank you for the opportunity. At the outset, I would give the apologies from Dr. Umang because he's not able to come, so I will be giving the talk on his behalf. So I'll be talking about the capacity building of the grassroots eye care personnel. There is definitely an inverse care law, and it applies to our country in totality, that wherever there is a greatest need for healthcare, there is a great difficulty in accessing that healthcare and the least likely to have their healthcare needs met. The challenges are to serve the most disadvantaged because we do have inequalities due to the socioeconomic status, geography, and gender. There may be a lot of talk going on to understand what really is needed, but the true fact is that people who live in villages do have to travel a lot of distances to get a primary level of care, and even in these places there is a shortfall of the personnel who are delivering this care. So in our situation, maybe the zip code is more important than the genetic code because of the imbalanced resource allocation, limited physical access to the quality health services, and inadequate human resources for health. This is a fact which has been printed over and over again, and this is from the latest issue, which says that the doctor to population ratio is not optimal, and this ratio is even lesser when we look at the paramedics or the other allied personnel. And therefore, this desperate shortage needs to be met. We may be going ahead with technology, but there is definitely a need to meet the manpower needs as well. The health workforce inequalities are even more glaring in the highly populated states of North India, where the workforce density ratio is much below the national average. Therefore comes a need that we require empowered allied health professionals who can be the leaders of change and play a critical role in improving the reach of the health services to these underserved areas. With that in mind, and a lot of help that we got from the Level Fund, we developed the Certified Ophthalmic Personnel Program, which we call the Jyotirgamya. The objective of this program is to empower the young women to have the appropriate ophthalmic knowledge, skill, and attitude. This in turn increases our work efficiency and strengthens the ophthalmic service delivery system and improves the quality of care. The focus is not only to empower them with the ophthalmic knowledge, skill, and attitude, but also to give them the computer skills, spoken English, and life skill education. So the method that we follow is that we have a designed curriculum which is divided into phases over the 2 years. There is a foundation course, a practical training, and on-the-job training. And the recruitment process is that we pick up girls from low socioeconomic background so that they can go back to their areas where they come from, and they can improve the healthcare systems over there, improve the accessibility to healthcare, and improve the availability of the eye care. So these students are inducted into the program in small batches, and there's a regular monitoring of the program by the created competency-based matrix. And we also have developed a career path for these students. So depending upon the aptitude, the young ladies are either put into the ophthalmic nursing assistant program or the medical record assistant, vision technicians, and ophthalmic counselors. And it has made a lot of difference in their worlds because they seem to have found a purpose in life. So the way that we are able to utilize these young ladies is that right from the eye camps to the hospitals, they help us in the registration process, the vision refraction, spectacle dispensing, intraocular pressure measurement, and fitness for surgery. And because of the involvement of these young ladies, we have had the decrease in postponement rate because we are better able to pick up the preoperative diseases which can be managed before the patients are taken up for surgery. They do a wonderful job in counseling, and this is because they are from the similar background. They are able to understand the patient's needs. They are able to communicate in the language and the dialect of the patient, and that makes a lot of difference when the counseling is concerned. There are satellite hospital where we have formed these workforces because of the girls which have been trained from that area. So therefore they go back to those satellite hospitals and they're able to work in good coordination with the team over there. So the impact has been that right now we are running the 13th batch. 299 students have been enrolled, of which 110 have graduated. It has been seen that after this program which has been brought in, the number of patients screened and the number of surgeries have increased. Of course, I would not say this is just because of the program, but it has made an impact on the clinical output. There have been an increase in the surgeries and the post-operative visits. There has been improvement in the quality parameters also, the vision, post-operative vision, the intraoperative time during surgery, post-operative infection rates, the OT starting time, the patient satisfaction index, and hand washing compliance. So the impact of the skilled and trained paramedics has brought about a reduced cost, but it has improved the quality and accessibility of eye care. It has empowered women and given them a lot of self-confidence. This young lady was from Mohammadi. She got trained in the program in September, and she's gone back to Mohammadi. And she says that her life has changed because of this program. She has become more confident, and her mother is elated with the transformation that she sees in her daughter. So this program has a lot of scalability, and there are too many needlessly blind. So definitely this program can help reproduce the similar kind of efficacy in the other locations as well. So we can reach out, give better outcomes, and more satisfied patients. The next phase of the program is accreditation and developing career pathways where the young ladies could become supervisors, tutors, and even have a lateral entry to nursing and optometry. The creating of replicable health training modules would be the advocacy for standardized training curriculum, engaging full-time and dedicated human resources, establishing the e-learning systems, and also networking with government and the other like-minded public and private agencies. So this is a healthcare which has become a team effort. The paradigm shift is from just being a doctor-centric approach, it is a multidisciplinary team approach which has brought about a change. And with this smiling lady who feels that she has been able to make a difference in a patient's life, I would say thank you very much for your attention.
What is the basic that you take up?
They are about 12 standard.
12. With science or any stream?
Any stream.
Any stream.
Because they are given a lot of the Initial curriculum is that they are given about the eye, the various structures of the eye and how everything works, and they're given English skills also. So it does not matter whichever stream they are from.
And what does COP stands for?
Certified Ophthalmic Personnel.
Thank you.
Thank you.
Nice talk. Thank you. I'll now invite RD Ravindran from catching up. He'll talk on the remote screening teleophthalmology.
Yeah.
Okay.
Thank you, madam. I mean, I'm going to just share some of how we do it. You heard about the vision centers and also the drone slit lamp from LV Prasad. Something similar to that, what we do in our setup also, will share it. So now, in the last, probably in the last 2 decades, our country has made great progress under the National Program for Control of Blindness. We were able to bring down the prevalence of blindness somewhere from 1.5, 1.6% to now probably about 0.5, 0.6%. But however, there are some inequalities. If you look at the rural location, there the prevalence of blindness is still higher compared to the urban locations. If you look at women, the prevalence is higher. And similarly, if they are unemployed, if the person is not married and they don't have any support, and again in this group the prevalence is still higher, and again it is much higher if a person is illiterate. At least the last survey shows that at least about 3 times higher in the illiterates compared to the literates. So it's not the same. Even though the prevalence has come down, we have not reached everybody. So in this situation, where most of these people are in the rural areas, illiterate, women, unemployed, they don't have any support, the screening eye camps have been the major route for most of the hospitals, most of the organizations across the country to reach this population, where we try as much as possible to replicate what we do in the hospital, creating similar different stations wherein the patients are registered, examined, refracted, intraocular pressure is checked, and then after final examination they are also taken to the hospital for surgery, and some follow-up examination is done. And the protocol and processes vary from hospital to hospital, but this is what is being done today. And when we looked at these eye camps, how effective are these eye camps, then we did a study sometime back, about 15 years back, to look at the reachability of these eye camps. We have done it in about 47 eye camps. Each eye camp covered about certain number of villages. From each of those camps, we picked up one village randomly and went to that village to understand how many people need eye care and how many of those people came to the eye camp. How many of them have eye problem and how many of them came to the eye camp. Then we found only about less than 7% of the people who need eye care in that population actually came to the camp. It was as high as about 15% if that selected village and where we held the camp was the same. And it can be as low as about 2 or 3% if they are very different, if it is far away from the eye camp site. And this highlighted the need for new strategies. If you have to cover everybody who need eye care, that is when we went ahead to do certain other things. One is we trained some village-based workers who will do door-to-door survey, examination, and refer the patients to the hospital. And also we also trained some of them to give presbyopic glasses. And we also looked at another option wherein we worked with the Indian Institute of Technology in Chennai to use their kiosk. We call it as Endlock. So this is one of the villages where they have a kiosk which is internet based. It is much earlier. I'm talking about year 98, 99. So we have this is a person in that center. She is able to take a picture of the eye using a webcam. And then she will ask some leading questions to the patient, and the patient will answer the things, like what is his complaint. And once this is recorded as an audio file, and then there is an email is sent to the hospital, where a doctor, we have developed a program where the doctor will look at the email, he'll listen to the patient's complaint, he'll also see the images of the eyes taken. And based on that, again, he'll talk back. This is again recorded as an audio file and then sent back to the particular center. All happens in a matter of about 24 hours. The patient again comes back to the center and then, then listen to what the doctor has said. And very often we have to ask the patient to come to the hospital. We didn't have any other choice. So based on that, we found that that may not work. So we created a permanent facility with about 2 technicians covering a population of about 50,000. And one of the challenge was, how do we give a comprehensive eye examination? How do we maintain the quality of care in such a situation, the screening? So we had created an infrastructure wherein we'll be able to do a complete comprehensive eye examination. We had 2 staff. One is a technician, other one is like a coordinator. The technician is a person who was well trained, kind of an optometrist. And initially, first 2 to 3 years, we also have an eye health field worker who will go door to door, screen and send the patient. And after a period of point of time, they may not be very relevant in the setup. And initially, we also had modified some of the digital cameras for taking the picture along, using the fitting in the slit lamp, and we take a picture. They are very cost effective. And we also, this is a kind of the workflow where we do the registration by the vision center coordinator. Then the technician examines the patient, does a slit lamp examination, also checks the intraocular pressure. And earlier we had that low cost camera. Now with the regular fundus handle cameras becoming cheaper, we are also able to use them. This is a non-mediatic. Then they do a teleconsultation with the doctor, and based on the consultation, whether we give the glasses. And the initial period, we didn't have the broadband connectivity, so we have used the low cost. We have put up our own towers to connect all these centers. And then we also had developed our own electronic medical record to facilitate the whole thing. And now the doctor is able to give a prescription for the glasses or for the medicines right from the base hospital. So this is the kind of a brief video. This is one of our center, which is about 25 to 30 kilometers. Today, we started in the year 2004 with the first center. Now we have about 65 centers. And the patients pay about 20 rupees for this consultation. So the technician examines, they do the refraction. The subjective refraction is also done. All this data is entered. Whatever she does is entered into the electronic medical record, which a doctor in the base hospital will be able to see when they connect. She also checks IOP, she does the BP measurement. All of course with us, and then they have been in the hospital at least for 2 or 3 years. So they all have reasonable amount of experience. So once all is done, this is the teleconsultation part. And then the doctor will be able to choose the center, the patient, and can see all the details. After seeing that, she talks to the patient directly and also to the technician. If anything has to be done by the technician will do it. Otherwise, she'll send the prescription, which gets printed out in the vision center. And the glasses are also provided. Here again, we have a set of about 60 to 70 frames, which a patient can choose. Once they choose the frame, and that again, the details goes back to the base hospital, where they are made and sent back. Earlier, we used to have grind and fix it, but with the plastic lenses becoming more popular, we don't do it anymore. Yeah. So, and again, some of the drugs for glaucoma and post-operative medicines are also. Can you go to the next slide? Yeah. So in the last year, the 2017, the 65 centers, we have seen close to about 500,000 cases. And also this is probably the second year wherein we have seen more outpatients through the vision centers than through the camps. The camps, we do about close to 2,500 camps. Even that, the numbers we see in these vision centers are much more than that. We have given these glasses, and that many cataracts were diagnosed. The compliance for cataract and for the specialty referral is low, but for the spectacles is very high. And about 1/3 of these patients also pay for the surgery. And similar data as what Rohit showed. These are all centers. There are 42 centers which had been there for more than 5 years, and they cover a population of about 28 lakhs or 2.8 million, and we have about 11 lakh patients, the unique patients in that population, which is a coverage of about 41%. So now once the center is there for about 3 to 4 years, probably we estimate that all the patients who need eye care, which means the people who are blind, who have severe visual impairment or moderate visual impairment, all we would have covered during this period. So that's about the comprehensive eye examination part. And we also do some DR screening. We do it in the urban area. We work with some of the diabetic clinics, wherein we have put the cameras, the fundus cameras. We have put slit lamps. We have trained these technicians there, and they are all usually within the same city, wherein they, with this fundus cameras, they are able to take the pictures. About 4 different fields are taken. They are uploaded. Once they are uploaded, they are sent to the main hospital, where they are read by one of the doctor, and the report is sent back to them immediately. So this has been working very effectively. But in the rural areas, what we have done is we have sent the cameras to the primary health centers where the patients come for collecting the medicines. And at that point of time, the patients are all screened. And again, these pictures are sent back to the main hospital, where they are again seen by the doctor, graded, and sent back to the primary health center immediately. And the doctors know which are the patients who need further care by an ophthalmologist. Similarly, we just saw a ROP screening. A very well successful program is being run in Karnataka by a doctor in Narayan Nethralaya, which is covering almost the whole state for ROP screening. Similarly, we have also, the first presentation by Dr. Parag was about how we are doing it. We are covering now about 12 districts. So in a way, if we have to come up with some similar systems. If you normally see in the health system designing, we put a lot of emphasis on developing hospital infrastructure, especially in our country. We put a lot of emphasis on developing secondary level. But screening, finding the patients who need care, and has to happen at that level. Many of them may not be able to, even though it is some facilities are available at the district level, they may not be able to come. And having the doctors, we can make some of the diagnosis screening for some of the diseases at the community level. But if we have to cover comprehensively everything, we need some of the technologies, which will go a long way in covering all the patients. And by that, we'll be able to truly give the universal coverage.